The antenatal period is very important because this is the time when we can actually screen for high-risk pregnancies and we can intervene very quickly. This is why it's very important for every woman to actually have equal and easy access to antenatal services throughout every corner of the country, and for every woman to actually attend antenatal. Grab a piece of paper, let's talk about antenatal care. Let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at antenatal care. If you haven't yet subscribed to the channel, hit the subscribe button, hit the bell notification icon to be receiving notifications of such amazing content every time I post. Drop a like and drop a comment to show some support. Remember that pregnancy is going to be divided into the antenatal period, the intrapartum period, and the postpartum period. The antenatal period is when the woman is pregnant, divided into predominantly 3 trimesters: the first trimester, the second trimester, and the third trimester. The intrapartum period is a period where the person actually gives birth, and the postpartum period, or the puerperium, is after they have given birth up to about 6 weeks. Remember that this antenatal period is going to be critical because it's going to be able for us to provide these life-saving interventions, and it creates this ideal platform for the provision of these integrated quality services for pregnant women as well as adolescents. Remember that antenatal care is this systemic care that we're going to offer pregnant women and their pregnancy, and this is going to be provided by healthcare providers. It's going to be a continuum of visits, or what we refer to as contacts now, that are going to start throughout the prenatal period up until through delivery and even in the postpartum period. Now, the whole objective of this is you want to ensure that the woman has a normal pregnancy and eventually a normal delivery and giving birth to a healthy baby, and the mother remains healthy even after the pregnancy. So that's why it's very important for every woman to actually attend antenatal care, such that proper antenatal care is going to be improving maternal and neonatal outcome. Before we actually go any further, there are a few definitions that I want us to get a hold of and actually understand. I have mentioned some of these definitions on the channel, but I just want to re-emphasize on some of them. The first one is maternal mortality, so which is pretty much the number of maternal deaths per 100,000 live births. So this can either be divided as direct obstetric death or indirect obstetric death. So a direct obstetric death is if a patient has a disease or an obstetric complication during pregnancy or labor or even the puerperium, or any interventions that are going to be given, or any omissions of interventions or incorrect treatment that is given to this woman that is directly leading to her demise. Now, these ones are going to be classified as pregnancies with abortive outcomes, hypertensive disorders of pregnancy, obstetric hemorrhage, pregnancy-related infections, obstructed labor, and even anticipated complications. These are directly going to cause a mother dying. Then, of course, indirect obstetric death are going to be caused by an aggravation of a pre-existing disease that was there, or a disease that developed during pregnancy by the physiological effects of pregnancy. Because remember, pregnancy is a state where the body changes significantly in the different systems. So these are going to be as a result of pre-existing cardiac diseases, skeletal diseases, neoplasms, endocrine disorders, autoimmune disorders, and infections such as HIV, TB, and malaria. And when we talk about neonatal mortality, this is just simply the probability of dying during the first 28 days of life, expressed as per 1,000 live births. Then when we talk about gravidity and parity, gravidity is just simply the number of confirmed pregnancies regardless of the outcome. As long as a person that has been pregnant and they have had a positive pregnancy test, then they're already gravida 1. Then parity is the number of deliveries after 20 weeks of gestation. And also these ones are regardless of the outcome, whether it was a live birth, an IUFD, or an MSB. So you have to take note that multiple pregnancies, twins, triplets, quadruplets, quintuplets, sextuplets, those are going to be counted as 1 in terms of gravidity and parity. Then, of course, an abortion or an abortus is just simply the number of pregnancy losses or abortions before the age of viability. In our case, I'm using 20 weeks in this presentation, but they may vary according to different places. Others have a threshold of 24 weeks, others have a threshold of 28 weeks. And this may either be spontaneous, therapeutic, elective abortions, or even ectopic pregnancies. Remember that the sum of the parity and the sum of the abortus is equals to the gravidity that you have. But in the American system, we actually record this as 4 numbers. So I'm sure when you look at some of the questions, they'll have 4 numbers, and don't get confused with all this. So the 4 numbers is just simply going to refer to the number of term deliveries, or those that gave birth after 37 weeks. The second number is going to be the number of premature deliveries or preterm deliveries. That's greater than the age of 20, but less than the 37 weeks. Then the third number is going to be the number of abortions. And then the fourth one is the number of children that are living, the number of children that are alive. So if a woman is pregnant, for example, and has had 1 term delivery, 1 set of twins at 32 weeks and 2 abortions, then we say that this woman is gravida 5 because she's been pregnant 5 times. So the first time that she had 2 abortions, so that counts as G2. She had a set of twins, that's 1, so that brings her to G3. And then, of course, she is pregnant. Actually, she has 1 term delivery, that brings us to G4. Then she's currently pregnant, that's G5. Remember, the twins are counted as 1. You don't count them as 2. So this woman is gravida 5. So she's G5, para 1, 1, 2, and 3. So it means she has had 1 term delivery, she has had 1 premature delivery, she has had 2 abortions, and she has 3 living children. So remember that factors are going to be influencing both maternal and neonatal mortalities, and these are going to be including a limited access to or low utilization of skilled birth attendants, as well as delays in them seeking antenatal care and reaching the care and getting this adequate care. So this is why it's very important to have a good understanding of antenatal care. It's not just a routine thing that a woman must come, you just see her do these routine things. You must be able to pick up certain pathologies during the antenatal care. So it's quite important for monitoring the pregnancy and as well as reducing the risk of morbidity and mortality for the mother and the baby during the pregnancy, delivery, and the immediate postpartum period. The high-risk pregnancies that actually don't attend antenatal are the ones that are actually going to give us a lot of complications, especially if they just come into the labor ward or they are referred late from a referral center, and they may actually even end up dying. Then, of course, the antenatal care is just simply this package of these regular medical and nursing care services that are going to be recommended during pregnancy, and are going to be comprising of certain things such as preventive strategies that are going to be aimed at providing regular checkup that allow the skilled healthcare professional to identify, to treat, and even prevent potential health problems that are going to be arising throughout the pregnancy. So what are our aims and objectives during antenatal? The first thing is we want to monitor for any maternal and fetal well-being during the pregnancy, throughout the pregnancy. We want to screen for high-risk problems. We want to prevent or detect or treat any complications quite early. We also want to educate the women on the physiology of pregnancy, the physiology of labor, and of course the identification of minor illnesses and danger signs in pregnancies. Because some women may be first-time mothers and they should know exactly what is not really normal in pregnancy and when they should come to the hospital, because they may think that it's normal, meanwhile it's actually abnormal and may result in death of the fetus, it may result in death of the mother. It's also important to guide on the nutrition as well as to guide the woman and her family plan for delivery, so making a birth plan. I will do a separate video on how to come up with a delivery plan or how to make a delivery plan. I'll give you some examples on certain scenarios on how to write a delivery plan. And of course, we want to discuss the contraceptive as she plans for future pregnancies. So remember, the WHO now refers to the times that the mother comes to the hospital as contacts and not visits. The reason why we emphasize for using the word contact is because contact is a more active word, and it means that it's going to be having this active connection between the pregnant woman as well as the healthcare provider, as opposed to visit, which is rather a passive thing where the mother is just going there just to visit. So it is recommended that a woman must have a minimum of 8 antenatal contacts as recommended by the WHO. This is done to reduce the perinatal mortality and to improve the woman's experience of care. Now remember that you're not limited to these 8 visits. You can actually have as many visits as possible. The more visits that you have, the better it is for you as a woman. But ideally, you should have a minimum of 8 visits. We shouldn't see women coming in labor and only having had 2 visits, 1 visit, and worse off if not having come to antenatal at all. That creates a lot of problems, especially during delivery. Then the first contact should ideally take place in the first trimester. So as soon as you discover that you're pregnant, you should come in. But this should be up to 12 weeks of gestation. But from my experience, most in our setting tend to book at around 16 weeks or even sometimes after. I've seen someone booking at 22 weeks. So the first contact is known as the booking visit or the booking contact, when you come in for the very first time as a pregnant woman. And of course, 2 contacts are going to be scheduled in the second trimester, so at 20 weeks and at 26 weeks. Then 5 contacts are going to be scheduled in the third trimester. So one is going to be 1 month apart, so from 30 weeks to 34 weeks. Then the others are going to be 2 weekly visits. If it's a high-risk pregnancy, you may even sometimes give them weekly visits. So 34 to 36, 36 to 38, 38 to 40, and after 40, if they don't deliver between 40 and 41, they should come back after 41 at 41 weeks of gestation if they haven't yet given birth. So this timing of these 8 contacts is to pretty much optimize specific interventions that we're going to be doing as part of antenatal in order to us to provide good and quality care. So this is moving away from the focused antenatal model, which actually recommended for only 4 visits. And remember that this systemic monitoring of maternal and fetal well-being, and particularly in relation to hypertensive disorders of pregnancy and even other complications that may be asymptomatic, is going to be actually achieved and best monitored through this model of antenatal care. So this is especially in the third trimester, because that's where we get to see a lot of these complications. So here is a summary. So the first visit ideally should be between 8 to 12 weeks. This is when you must actually even get an early ultrasound, because this early ultrasound will enable us to date the pregnancy quite accurately. Because remember, an early ultrasound between 8 to 12 weeks is pretty much going to be quite accurate, more accurate than your dates that you're giving based on the last menstrual period. So the first contact must be up to 12 weeks. That's in the first trimester. Then the second trimester is going to be, the second contact would be roughly at 20 weeks. Then the next contact would be 6 weeks after. So that's going to be at 26 weeks. Then in the third trimester, we have pretty much these are the contacts. So the fourth contact is going to be at 30 weeks. The fifth contact is going to be at 34 weeks. So that's 4 weeks apart. Then after that, you give them 2 weekly visits. So the 6th is at 36, the 7th is at 38, and the 8th is at 40 weeks. If it's a high-risk pregnancy, we even give them weekly visits. Then this is the previous focused antenatal care, which only had 4 visits. So the first visit is at 8 to 12 weeks. The second is at 24 to 26 weeks. The third visit is at 32 weeks, and the fourth visit is at 36 to 38 weeks. So we now want to follow this schematic where we want to give them 8 contacts. So what are some of the recommendations that we should do in antenatal? So remember, the first visit or the first contact must be before 12 weeks. That's the very first thing. The second thing is we do give this woman intermittent preventive treatment, intermittent preventive therapy, because remember, we want to prevent them from catching diseases like malaria. So this ideally should be given at 13 weeks, and then you should give it 1 month apart for at least 3 doses, but you can actually even go up to 6 doses, especially in women that are at risk of contracting malaria. Our prophylactic drug is going to be Fansidar, which is a combination of sulfadoxine and pyrimethamine. So usually in our setting here, we start roughly at around 16 weeks, then we give a dose every 4 weeks. Then after 36 weeks, there's no Fansidar that is given if the last dose was received less than a month ago. Then of course, this must be given with directly observed therapy. You must actually see the woman taking the pill and swallowing it, and not giving her the pill and asking her to go home and take it. She may not take it. Then of course, you should account for the stocks that are given. Iron, about 30 to 60 milligrams, and folic acid, 0.4 milligrams can be given or should be given. Remember that daily iron and folic acid supplementation are going to reduce the risk of many things, including things like maternal anemia, low birth weight, puerperosepsis, as well as preterm labor. In the absence of 0.4 milligrams folic acid, we can actually give 5 milligrams. It's actually quite acceptable. But remember that whenever you give in this high dose of folic acid, the 5 milligrams, this may actually even interfere with the effectivity of the sulfadoxine and the pyrimethamine. So it means about 2 weeks before you give this sulfadoxine and pyrimethamine, you must avoid giving them the 5 milligrams of folic acid within the dose of this Fansidar, because it will be rendered ineffective. Then remember, folic acid is important or useful in pregnancy up to 12 weeks because it's going to be preventing the formation of neurotube defects. Remember, folic acid is needed for DNA synthesis. And anyone at any point of pregnancy, if they have an HB that's less than 11, we want to treat them for anemia in pregnancy. We want to investigate them and find the cause, and we want to treat them, ideally giving them the folic acid as a 5 milligrams orally once a day, and ferrous sulfate 200 milligrams 3 times a day. Remember that ferrous sulfate is very important, especially in the second trimester. Then we also want to get an early ultrasound before 24 weeks of gestation. This is recommended for all pregnant women. Ideally, a woman must have at least one ultrasound each and every single trimester. They are also encouraged to use insecticide-treated mosquito nets and be sleeping under these insecticide-treated mosquito nets. Immunization is also quite important. Remember that the vaccine that we give routinely in pregnancy is tetanus. So routine vaccination of tetanus, we generally administer at least 2 doses before delivery. So the first dose should be given as soon as possible during the pregnancy, and then the second dose should be at least 4 weeks after the first dose, and then at least 2 weeks before the due date of this patient. And then after delivery, we continue the vaccination until they have received the recommended 5 doses. But in our setup here, generally we just give them about 2 or 3 doses of tetanus. And of course, to ensure that there is protection against maternal as well as neonatal tetanus in women that have never even been vaccinated before, then we should give them a minimum of 3 vaccines or 3 vaccination series. And this is going to be consisting of tetanus as well as reduced diphtheria toxoid during pregnancy. So we give them at 0 weeks, 4 weeks after, then at 6 to 12 months. Remember that the vaccine that's going to be consisting of tetanus, diphtheria, and acellular pertussis is the one that should replace the 1 dose of tetanus and diphtheria only that was given at 27 and 36 weeks of gestation. If a tetanus and diphtheria booster is actually indicated in pregnancy, for example, if the last time they got this vaccine was 10 years ago, or the previous vaccine that they had received and was quite some time back, then the healthcare provider can actually administer the tetanus, diphtheria, and acellular pertussis vaccine during the pregnancy within that same period of 27 to 36 weeks of gestation. We want to avoid any live attenuated vaccines such as rubella, measles, mumps, and yellow fever, because there is theoretically a chance of the woman actually developing reactive disease, so we don't give these. But the toxoid vaccinations such as rabies, hepatitis A and B can be given to pregnant women just like non-pregnant women, especially if they are at risk. So what are these contexts that we have? So ideally, women that are planning to become pregnant should actually see a physician before they actually even decide to get pregnant, so that they can learn the risk of pregnancies, they can learn the risks of how the ways of how to reduce these risks, and they can also get this preconceptual counseling that is needed, especially to give birth to a healthy child. So as part of this preconception care, the primary healthcare clinicians must actually provide all women that are of reproductive age aiming to get pregnant the vitamins that are needed, that are going to be consisting of folic acid 400 to 800 micrograms, that's about 0.4 to 0.8 milligrams once a day, and this is going to be reducing the risk of neurotube defects. And remember, if a woman has ever given birth to a fetus or an infant that has had neurotube defects, then they must receive a recommended daily dose of 4,000 micrograms. That's 4 milligrams of folic acid once a day, because this is going to be reducing the risk of neurotube defects. Is also going to be reducing the risk of other birth defects. And of course, evaluation is often required for signs and symptoms of the illness. And remember that you must educate them on the common symptoms that we see that are often pregnancy related, things like vaginal discharge, pelvic pain, nausea and vomiting, lower extremity edema, but remember, do not prescribe furosemide for this edema, backache, constipation, leg cramping, heart pain, and even varicose veins. And then remember that these prenatal visits may be scheduled more frequently if the risk of poor pregnancy outcome is high, and less frequently if the risk is very low. So it's at the discretion of the patient, of the healthcare provider that is actually seeing this patient. If you deem that this patient needs more visits because it's a high risk pregnancy, give them more visits. But if it's a normal pregnancy, unremarkable, you may give them less visits in some cases. So what do we do at our first contact? So this one is going to be referred to as our booking date. And generally, this should be done up to 12 weeks or any time when the woman actually presents. So ideally, the first contact should be as early as 6 to 8 weeks. And the main focus of this is actually to provide this antenatal counseling on nutrition, the birth preparedness, and even danger signs of pregnancy. So we want to assess the health status of the mother and the fetus. We want to ascertain the fetal gestational age. We want to order for certain baseline investigations. We want to plan for continued maternal care and risk assessment. Advise the mother to always keep coming for antenatal. Then, of course, some medical assessment and management are also provided. Intimate partner violence as well as sexual and gender-based violence should be inquired and should be reported if present. Then, of course, During these visits, we're going to be doing three main things. We get a full medical history, including certain vital statistics. We do a physical examination, a full physical examination, and we order for certain laboratory and radiological investigations. So what do we do on our history? So on our demographic and vital statistics, we want to get the name, obviously, of the patient, the age, the gravidity, the parity, the last normal menstrual period, the expected date of delivery, the residence and occupation, the complaints or history of current complaints if they have any previous or current disorders, the past medical history or surgical history, drug history or therapeutic or social history. Then also you want to get your past obstetric history with the outcome of all the pregnancies, including the maternal and fetal complications. We also want to screen for things like gestational diabetes mellitus, preeclampsia, congenital malformations, stillbirths. We want to get a current obstetric history. We want to also get certain risk factors for complications of pregnancy. So things like pre-existing maternal disorders, any physical or social characteristics such as age. Remember, an age greater than 35 years puts a woman at risk of many obstetric conditions. And of course, problems in the previous pregnancy such as preeclampsia, problems that may develop during the pregnancy such as hypertensive disorders of pregnancy, diabetes, sexually transmitted infections, pyelonephritis, and even certain problems during the labor and delivery. We want to get a family history, asking for those certain familial comorbidities, a socioeconomic history, and then on the subsequent visits, we want to actually get history on particular things, whether there's any vaginal bleeding or vaginal discharge, whether there's any headaches, whether there's any changes in the vision, whether there's any edema of the face or the fingers, if there's any changes in the frequency or intensity of the fetal movement. So here is an example of an antenatal book. Sometimes you may get this on the antenatal card. Unfortunately, I didn't add this to the antenatal card. So this is the first page when you open the book that you're going to see. So I've actually redacted this page or this picture so that I actually maintain the confidentiality of this particular patient whose book where I got this information from. So the first thing that you fill out there is the surname, then you have the full name over there, then the other names if they have other names, you put their date of birth there, their age, then of course their religion, the church that they attend to, their residential address, the level of education, the location or landmarks, and the name of their husband, the occupation of the husband, the telephone number of the husband, the name of the guardian, the occupation of the guardian, the telephone number of the wife. Then of course there are certain things that you fill in over here, and of course here are some abbreviations that I want you to remember. So PCR here means patient or pre-testing counseling refused. So the patient refused any pre-testing counseling. That's what the PCR stands for here. Then the PCA is just simply prenatal counseling accepted if they did accept. Then of course the TR here is test refused, if they refuse to get the test. The TA means test accepted, they accepted to get the test. The R means for reactive, meaning if the test came out reactive. Then the NR is for non-reactive, meaning the test came out non-reactive. The I is for indeterminate, meaning you're not so sure whether it came out negative or positive. The MGRA, which is supposed to be this one here, the MGRA is going to be the maternal given the antiretroviral drugs rather. Then of course the IgA is the infant given the ARVs. Then the INGA, the infant not given the ARGs, then the ARVs rather. Then of course the IFB here, it means that the infant feeding choice by the mother was breastfeeding. Then this is supposed to be IFR, which is the infant feeding choice by the mother is replacement feeds. So this is how you're going to be filling this in. So for this particular woman here, this woman refused pre-testing counseling, but she did accept to get the test done, and when the test was done, it did come out negative. Then the retest was done on the 12th, and this also came out negative. Then here we have our past obstetric history, where you can actually put the number of children that the woman has had. So the number there, the year, the health during the pregnancy, if they've had any illnesses, you record that here. The duration of the pregnancy, whether it was a term, preterm, the number of weeks the pregnancy actually lasted, the duration of labor, if the woman can remember. Was it a spontaneous labor, was it an instrumental delivery, or was it a C-section? The sex of the child, the birth weight of the child, of course the status of the pregnancy, whether it ended in a live pregnancy, a miscarriage, a fresh stillbirth, a macerated stillbirth, or whether the child died later on, and if they died, what was the cause of death. And of course, any problems that were there during the puerperium, you record this. Then, do they have any family history of twins? No or yes. Then, of course, any of these previous illnesses such as TB, heart disease, high BPs, kidney disease, diabetes, anemia, asthma, malaria, STIs, epilepsy, and sickle cell. So you can either take no for this or yes for this. If you tick yes for it, you have to put the details over there of when they were found positive with this, and if they were treated for it or if they are on treatment. Any previous C-sections, so this woman has had C-sections for both of these pregnancies. Then of course, any allergies, there are non-allergies for this woman. Then she has to consent for the operation in case she actually, all women must actually sign this in case they actually get into labor and you deem that they do need a C-section. At that particular time, they may not be in a right state of mind to actually decide that they need a C-section, so they put their name there. They consent for C-section. If they are doing a bilateral tubal ligation plus or minus BTL, then the date, so this is supposed to be, this should have been the 26th of the 6th month of 2023. So this was actually filled in wrong. Then the signature and the witness over there. So you must make sure that all women signed, and remember you can only sign this if you're above the age of 22. Below that, you can't really sign this consent, then your guardian has to sign the consent for you. Then when it comes to the physical examination, we want to do a full general examination. So we want to get our blood pressure, we want to get the build, we want to get the height, we want to get the weight. Then of course, any pallor, jaundice or cyanosis, the oral cavity, examine the neck, examine for edema, do a urinalysis on this patient, calculate your BMI, your body mass index, do your BPs, and your weights should be done ideally at each prenatal visit. Then of course, you must do a systemic examination of the lungs, the heart, and as well as the abdomen for any organomegaly such as the liver and the spleen. So the initial obstetric examination or the speculum as well as pelvic bimanual examination must be done to check for any lesions or discharge, to note the color and consistency of the cervix, and to obtain certain cervical samples. Remember that during these subsequent visits, you're going to be just checking the BP, the weight, and doing an obstetric examination that's going to be focusing on certain things. It's going to be focusing on the uterine size, the fundal height in centimeters above the symphysis pubis, the fetal heart rate, the fetal activity, the maternal diet, the weight gain, as well as the overall well-being of the mother. The speculum and the bimanual examination are not needed necessarily unless if there's any history of vaginal discharge, any bleeding, any leaking of fluid, or any pain that is present. Then of course you should also estimate the pelvic capacity, and you should assess clinically if this woman has an adequate pelvic capacity in order to give birth. Remember that this can be estimated clinically by evaluating various measurements with the middle finger when you perform the bimanual examination. So if the distance from the underside of the pubic symphysis to the sacral promontory is greater than 11.5 centimeters, then the pelvic inlet is actually almost certainly adequate. So normally the distance between the ischiospines is greater than 9 centimeters. Then the length of the sacrospinous ligaments is about 4 to 5 centimeters. Then of course the suprapubic arch must be greater than 90 degrees. So in a patient that presents later in pregnancy, then we can determine the lie of the fetus as well as the fetal heart rate. So again, coming back to this is our page 2 of the book. So you fill in your LMP there, your parity, your gravidity, the date of quickening, where they started perceiving fetal movements, the expected date of delivery, of course the menstrual history, so the amount of flow, the duration, whether it's irregular or regular, how many days is their cycle. Then the general condition of the mother, the height, the heart, the lungs, the teeth, if there's any varicose veins, the breast, of course if they've done any smears, any chest x-ray results, any transfusions that were given, the blood group of the patient, the RH group of the patient. Then we record the antenatal record here, the date when they came in, the number of pregnancy by dates, the fundal height if it's palpable, the position if it can be determined, the presentation, and the lie if it can be determined, and whether it is engaged. We should record the fetal heart rate over there, the BP, the pulse, the weight of the mother, any presence of edema. On the urinalysis, we're interested in any proteinuria, any sugar, any glycosuria that's present. Is there any pallor, and of course the next appointment. If they do any investigations, you may include them on this small column there and you fit it in over there. So as you can see, this has many spaces, and it means the woman can actually attend antenatal as many times as she wants. Then laboratory tests are going to include urine and blood tests. So some tests are going to be repeated during the subsequent visits. Then some of them are just done at the initial visit. But initially, that's when you're going to be doing most of these tests. So we do a full blood count to get our booking HB. We get our blood typing and our RH grouping. We do a hepatitis B serological test. We do a random blood sugar and HIV test. So these are routinely done in our setting. We do serological test for syphilis. That's our RPR. Then we rarely do rubella and varicella immunity in our setup. We sometimes do cervical cultures, especially for suspecting gonorrhea and chlamydia infections. We do cervical papinoculo, that's the pap smears we do. We do urinalysis for proteins and glucose determination. We do urine MCS, and of course we screen them for TB. Our urine LAM as well as our sputum gene expert and sputum MCAs. Remember that we should generally avoid x-rays in pregnancy. We can only do shielded x-rays if the benefits are going to be outweighing the risks. Because remember, these x-rays can actually induce spontaneous abortions. They may cause congenital malformations, particularly early in pregnancy. Then we should also order for a pelvic ultrasound. So again, all those details, you record them over there. If, of course, this patient here at this last visit, they got FBC, a cross-match, an ultrasound, RPR was done, RVT, hepatitis B was done on this last visit that they came in. Then the medications we often give in antenatal is hematinics, that's the folic acid and ferrous sulfate, tetanus prophylaxis, that's your tetanus toxoid, and then ideally you should receive a minimum of 3 doses, but for the entire pregnancy they must receive 5 doses, including the puparium. Then of course Fansidar must be given if the pregnancy is above 16 weeks. Then of course ART, antiretroviral treatment if they're reactive and they're not on treatment. If there's any special notes that are important that you need to put there, you put them there. If there's any special investigations that have to be ordered, you put them over there. So as you can see here, the first test where you do your RPR, the date when you do this, and the result. If they're not reactive, then they don't need treatment. If they are reactive, then they need treatment. The drug, first dose, the second time you check for the RPR, then of course the third dose. And of course, so this is supposed to be second dose here. Then the second date where you check for the RPR, the result, if you're treating them, the drug and the dose. Then the first HB that is done, the result, if there is any treatment, the drug and the dosage. Then of course the second time you're doing your HB, the result, if any transfusion is actually given to this patient. If there's any iron that's given to the patient, folic acid that's given to the patient, malaria prophylaxis that's given to the patient, we record there. If the patient is actually dewormed, we actually record there. So that's what we do in the first visit. So at the second contact, this is going to be done at 20 weeks. So you review the results of the investigations you ordered at the first visit. So if the HB is less than 11, we treat them for anemia. We order an ultrasound for any fetal anomalies. We continue the medication. We give them the second dose of sulfadoxine and pyrimethamine. We deworm the patient as well as give them hematinics. If the HIV test was missed at the previous visit, we do the HIV test at this visit. If it comes out positive, we start them on treatment. If it came out positive from the initial booking date and they didn't start treatment, then we start them on treatment. Then the third contact is at 26 weeks. We review the ultrasound and record on the antenatal card. We repeat the RPR in HIV if the initial tests were negative. We emphasize on the birth preparedness, and then we give them the third dose of the sulfadoxine and pyrimethamine, continue them on hematinics. The fourth visit is going to be done at 30 weeks, so we repeat the full blood count and we give them the fourth dose of sulfadoxine and pyrimethamine. That's our Fansidar for the malaria prophylaxis. The fifth contact is going to be at 34 weeks, so we re-emphasize on birth preparedness because they're coming very close to term. If we are HIV positive, we must get the viral load, because remember, viral load must be done at least 4 to 6 weeks from the expected date of delivery. Then of course we give them the fifth dose of sulfadoxine and pyrimethamine. At the 6th week, then they're going to be at 36 weeks, so we ascertain the presentation, we continue them on hematinics. If they haven't done viral load testing, we check for the viral load. We counsel them on adherence for the mothers that are actually on antiretroviral treatment. If they haven't yet started treatment, we start them on treatment. Then the 7th contact is going to be at 38 weeks, where we give them the last dose of sulfadoxine and pyrimethamine. That's at dose number 6. Continue them on hematinics. Then of course counsel them on ART adherence and they should continue ART if they are on ART. Then at 40 weeks, which is the 8th contact, we ascertain the presentation again. We repeat the HIV test if it wasn't done, or if it was done but way back beyond 3 months ago, we repeat the test. Then of course the viral load testing, if it's not done at 36 weeks, we do it. Then of course we counsel them on adherence of ART. And then this visit is very important, because if a woman doesn't go in labor, she must come back at 41 weeks. We don't want any woman to go beyond 41 weeks minus them not coming back to the hospital, so that we can actually deliver the patient either by inducing them or actually taking them for a cesarean section. So if we do find out that the woman is positive, remember that HIV at booking, if positive, will refer them to treatment immediately. They must start treatment. We retest the woman if they're negative every 3 months. Then all women that are positive and they are pregnant must be started on cotrimoxazole or prophylaxis. And all the positive mothers, their files must be sent to MCH, and we must conduct the viral load at 34 weeks of gestational age. So ideally 1 to 4 weeks before delivery. Then at 6 weeks postnatal, we must check the CD4 count, and if it's greater than 350 cells per microliter, then of course we may stop the cotrimoxazole prophylaxis. Remember that all HIV-exposed infants must start on prophylaxis for at least 12 weeks with AZT, 3TC, and nevirapine, and we can actually discontinue it if the mother is virally suppressed after 3 months postnatal. Then in a situation where we actually don't know the viral load of the mother and we don't know whether they are suppressed, the prophylaxis can actually be continued while we closely monitor for any side effects in the baby. Then of course the prophylaxis should be extended until we are actually certain that the mother is virally suppressed, or after 4 weeks after they stop breastfeeding. Where the mother actually refuses to be on treatment, we continue to counsel them, and then ART should be initiated as soon as possible, and we make sure that we keep the baby on extended prophylaxis. What is just some of the advice that we give antenatal patients when they come into the antenatal care? So one thing is diet. We must keep it realistic. We must have a balanced and a light diet. It must be nutritious. It must be easily digestible. It must be rich in proteins, minerals, and vitamins, especially vitamin A and D. We should advise them to avoid overeating, as this can cause weight gain, overweight, and this may actually predispose them to more complications. We should give them supplementary iron and folic acid. Hygiene is very good, because you must tell the women to continue bathing normally, because pregnancy is not an illness. They should bath every single day, and they must have dental care brushing. Then we advise them to get enough rest and sleep, so women can actually do their normal routine activities, and mild non-strenuous exercises can be permitted as they are tolerated. Then you should advise them to wear loose, comfortable clothing. This should be well-fitting, comfortable bras. Then of course they should avoid any high-heel shoes, especially in the late pregnancy when the center of gravity actually changes. Coitus is generally not restricted unless if they have APH, that's placenta previa, if they have a history of draining, if they have a history of cervical incompetence, if there's any recurrent miscarriages, if there's any preterm deliveries, we avoid them from having coitus. Then of course traveling, if it's a bumpy road, they should avoid this in the first trimester, if they've had a history of miscarriages. Air traveling can actually be safe up to 36 weeks of gestation, but generally we want to avoid it in certain cases like patients with placenta previa, those that are draining, those with cervical incompetence, those with a recurrent history of miscarriages, those with preterm deliveries, those with preeclampsia, severe anemia, sickle cell disease, chest infections, or thromboembolism. And remember, when these patients are traveling, they must desist from actually sitting for a prolonged period of time, because this puts them at risk of their blood pooling in their lower extremities, and they may actually develop thromboembolism. Smoking and alcohol should generally be avoided in pregnancy whatsoever, and generally we should avoid any unnecessary drug intake, especially in the first trimester, because this is where organogenesis is happening. So a lot of these drugs can actually affect the organogenesis of the fetus and can result in certain birth defects. So generally we want to avoid them during pregnancy. Then of course we want to advise them on early identification of certain danger signs and when they should come into the hospital. If they see any PV bleeding, if there's any severe headaches, if there's any gush of vaginal fluids, if there's any severe abdominal pains, any severe back pains, if there's any shortness of breath, if there's any history of fainting, then this woman must come into the hospital, because these are danger signs that may be pointing towards certain conditions that may increase the morbidity and mortality for the mother as well as the fetus. I really hope you learned a lot on antenatal care and the different things that we do in the antenatal clinic. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.